If an arthritic joint hurts when you move it, is movement wearing it out, or could movement be part of what helps it keep working? That question sits behind ordinary moments: opening a jar, standing from a chair, climbing stairs, or walking the dog. Pain can make rest feel like protection. The common story is simple. The joint is worn. Movement creates friction, so less movement must mean less damage. It sounds logical. It is also too simple for the biology, and too simple for the way people lose function. The more useful question is not whether movement is good or bad. It is which process is affecting the joint, what the joint can tolerate now, and how movement changes strength, control, confidence, and daily load over time. This matters because arthritis is not one disease. Pain in two joints can feel similar, while the processes underneath are very different. Before asking how much to move, we need to know what kind of problem movement is entering. A joint does not work alone. In the supplied source, knee and hip function depends on surrounding muscles, movement pattern, balance, and sensory feedback. That gives us a useful source-based model. Joint symptoms sit inside a larger movement system. In osteoarthritis, changes in the joint can alter how load is handled. The source focuses on what follows: pain, reduced knee bend, different walking patterns, and less comfortable weight bearing. The story is not simply that movement equals damage. The joint and the way the whole body moves interact. Rheumatoid arthritis begins from a different direction. The immune system mistakenly drives inflammation in the joint lining. It often affects smaller joints in the hands and feet, can involve several joints, and can affect tissues beyond the joints. That distinction changes the treatment target. Osteoarthritis management often focuses on symptoms, load, function, and tissues around the joint. Rheumatoid arthritis needs control of the immune-driven disease. Exercise can matter in both, but it does not do the same job as disease-modifying medicine. A painful knee after years of osteoarthritis is therefore not the same clinical problem as new, swollen joints from inflammatory disease. Assessment matters when inflammation persists, several joints are involved, or symptoms extend beyond the joint. Arthritis changes more than a scan. Knee osteoarthritis can alter walking. People may bend the knee less, shift load differently, shorten a step, or spend less time on the painful side. The body is solving a problem in real time. Those adjustments may reduce discomfort in the moment. Repeated compensation can also change the work demanded from the hip, ankle, and other leg. A joint problem can become a movement system problem. Hip pain shows the same principle. Weakness in the gluteal muscles can reduce control of the pelvis and thigh. The body may find another route through the movement, affecting balance, walking, and load at neighboring joints. With rheumatoid arthritis, the system can widen differently. Several joints may become painful or swollen, and the disease can be associated with effects involving bone, lungs, or the lining around the heart. A multi-system condition cannot be reduced to local pain relief. Pain also changes behavior. When an activity repeatedly hurts, people naturally do less. Less use can mean less strength, less aerobic fitness, and less confidence. Then the same task demands a larger share of a smaller capacity. This does not mean pain is imaginary, or that every painful movement should be pushed through. The source shows why pain is not a simple damage meter. Symptoms are shaped by the joint condition, muscle function, balance, and the demands of the task. One score cannot tell the whole story. Treatment makes more sense when we ask what each option is trying to change. Some approaches reduce pain, some reduce inflammation, some slow immune-driven disease, some improve capacity around the joint. No single tool covers every target. Analgesics may reduce pain without changing the underlying joint process. Non-steroidal anti-inflammatory drugs can reduce pain and inflammation, but may bring gastrointestinal, kidney, blood pressure, or fluid retention risks. The balance depends on the person and medicine. Injections into a joint, including corticosteroids, may offer short-term relief for some people. Relief can create a window for function, but a temporary fall in pain is not the same as rebuilding strength or changing the whole disease course. For rheumatoid arthritis, disease-modifying anti-rheumatic drugs, including methotrexate and biologic treatments, target the inflammatory process more directly. Their role is not simply to mask pain, it is to control disease activity and reduce continuing joint damage. These medicines need clinical monitoring because the source notes possible liver and kidney harm. That is not an argument for or against them. Decisions weigh the harm of uncontrolled disease against the risks and benefits of treatment. Joint replacement can transform life when arthritis is severe, but surgery is not the end of the movement story. Weakness can persist after hip replacement. A new joint surface still needs a capable movement system around it. Exercise is not a rival to every medicine. It is a different category of treatment. It can improve strength, fitness, control, and function, while medicines may address pain, inflammation, or disease activity that exercise cannot safely replace. Now the movement paradox becomes clearer. A painful joint may tolerate less load today, yet avoiding load completely can reduce the muscle and control that help manage tomorrow's load. Protection is sometimes necessary. Permanent underuse carries its own cost. Muscles do not replace cartilage, but they can change how force is produced and controlled. Quadriceps help with standing, stairs, and walking. Hip muscles guide the thigh and pelvis. Hand strength supports jars, bags, and daily grip tasks. Research cited in the source links stronger quadriceps with a substantially lower risk of knee osteoarthritis. That supports a protective role for strength, but it is not a personal guarantee and does not prove one muscle determines whether arthritis develops. Exercise can improve pain and function without the systemic drug effects attached to some medicines, but exercise still has a dose. The wrong load, a rapid increase, an active flare, or poor recovery can worsen symptoms. More is not automatically better. That is why arthritis exercise is not one universal routine. The useful mix depends on diagnosis, joints involved, current symptoms, balance, other health conditions, goals, and previous training. Tailoring is the mechanism that makes the program fit. Aerobic exercise trains the heart and the ability to keep moving. Land-based training has shown moderate benefits for aerobic capacity, pain, and quality of life. In rheumatoid arthritis, combined aerobic and resistance work may also improve cardiovascular risk factors. Walking is one option, not a test of character. If walking is difficult, cycling changes the balance demand and how load is applied. Water can support body weight and make movement more comfortable, although the cardiovascular stimulus depends on effort. Resistance training builds force for ordinary tasks. A chair squat rehearses standing. Knee extension trains the quadriceps. Hamstring work supports walking and stairs. Rows and presses can help with groceries and reaching. Putty can train grip for jars and bags. Studies use a wide range of resistance loads, session lengths, and weekly frequencies. That tells us there is no magic prescription. A research range should not be copied as a personal plan without considering pain, technique, recovery, and disease activity. Flexibility work has a narrower job, maintaining or improving usable range. Static or dynamic stretching may help, but forcing a painful stretch or using uncontrolled ballistic movement can turn a range exercise into an irritation exercise. Neuromotor exercise trains balance, coordination, and movement quality. Tai Chi and yoga can challenge control while slowing the task. This becomes especially important when arthritis has changed balance or the sense of where a joint is. The four jobs overlap, but they are not interchangeable. A walk may train fitness and leg endurance. It will not fully replace progressive strength work. Stretching may improve range. It will not by itself rebuild force or control. A useful program connects capacity to life. The point of a chair squat is not the squat. It is standing with less effort. The point of grip work is not stronger putty. It is the jar, the bag, the dog lead, and the independence attached to them. Strength is only part of control. Proprioception is the body's sense of position and movement. It lets you know where a knee, ankle, or finger is without watching it. Think of it as an internal position signal, not a conscious calculation. Receptors in joints, muscles, and tendons send information to the nervous system. The brain combines those signals and adjusts muscle activity. This loop helps stabilize a joint before, during, and after the foot meets the ground. In knee osteoarthritis, proprioceptive accuracy can decline. Research also reports poorer balance, more sway, and altered muscle activation. Similar changes may appear across knees, hips, and ankles. The result is a different way of loading the system. Balance and neuromuscular training give that system practice. Dynamic balance tasks, Tai Chi and controlled direction changes can challenge the loop between sensation and response. The goal is not perfect stillness, it is a better correction when movement shifts. External supports, such as an elastic knee bandage, may increase sensory feedback for some people. That may improve awareness in the short term. It does not rebuild every part of strength, range, and control. So support is added information, not a cure. This hidden sense explains why management often combines strength, range, balance, and task practice. The joint does not act alone. It sits inside a sensing, responding movement system. Prevention needs careful language. Not every case of arthritis is preventable, and no habit guarantees healthy joints. Modifiable factors can still alter load, capacity, and disease risk, or change how symptoms affect daily life. The source links modest weight loss with reduced arthritis pain, but it does not establish one guaranteed response for every person. The careful meaning is that weight management may change symptoms for some people, not that body size determines pain. Regular activity and strength work can protect capacity. Footwear or orthotics may help when a specific mechanical problem and the chosen support match. Joint protection strategies can redistribute difficult tasks. None is universally effective simply because it sounds sensible. Smoking is relevant to rheumatoid arthritis because it is associated with greater risk and severity. Medication choices also need context. A treatment that relieves symptoms may carry risks, but uncontrolled inflammation, pain, and inactivity carry risks too. A better arthritis plan has 3 layers. First, identify the disease process. Second, build the movement system's capacity and control. Third, fit both to the person's daily tasks, health conditions, preferences, and changing symptoms. So, does movement wear out an arthritic joint? Not in that simple sense. Movement can irritate a joint when the dose or timing is wrong. It can also preserve the strength, fitness, balance, and confidence that make movement possible. The answer is not endless rest or relentless exercise. It is informed, adaptable loading inside the right medical context. Arthritis becomes less confusing when pain, disease, and movement stop being treated as the same thing. The full BeSund article and its supporting references are linked in the description if you want to examine the detail behind this explanation.